Well, Sandra's here with me, so
Hey, 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 it's Cannonball Nation. It is May 22nd, 2025, and today we are going to be talking about the basics of Medicare. We are starting a kind of a mini Medicare boot camp series. So today we're going to be talking about the Medicare card specifically and how you break that down for a client. And so I'm going to share my screen of slides for y'all today. Okay. Now, so when we talk about original Medicare, one of the things I like to do with my clients, especially when I'm teaching them Medicare, is either A, get their Medicare card where they have a visualization, or I actually have what you see on the screen in an 8x10 laminate. So I have the sample Medicare card and the little line items all on there, and it's laminated. And I personally walk through the Medicare card with a client with the lamination, and I fill in the line items. So the line items are specific for specific things, and we fill all those in as we're giving our kind of new to Medicare presentation. But I always start with the Medicare card because I'm a big believer. You can't pick out the plan you want to go with your Medicare card if you have no idea what the actual Medicare card even does for you. So I always like to start with the Medicare card training and just teach the client, what's part A, what's part B, and what all that means. And we're going to get into filling it out here in a little bit. But first, I want to break down these parts of Medicare. So you got part A and part B. You have obviously your name, you have a Medicare number that looks kind of like a VIN number on a car. Way back when, that was a social security number with like a letter A behind it. But they changed it several years ago for security. I don't know why they didn't think to change it much sooner than that, but they didn't. And then on the right-hand side of the parts A and B, you have the coverage start effective dates. As you can see on the sample card, they are the same effective date, but they can be different effective dates as well. So if you see somebody with different effective dates, don't freak out. That actually can happen quite often, more often than not. So they do mean different things, and we'll get into that later in the series, but just know the dates can match or they can be different. Now, when we talk about Part A is your inpatient hospital care. So think of this as kind of like your room and board coverage. So it's going to cover your inpatient hospital stay. It's going to cover skilled nursing, hospice care, and some home health care. Very limited there, but it does cover some. And when you think of room and board, so like if you check into the hospital, then your Part A is going to be what they bill. Now, for 2025, the we're going to go through the Part A costs, but something you need to know, especially as a new agent, every year, these prices, the copays, the deductibles, the premiums, all that changes every year. So this is not a set in stone thing. It does change every year. So in 2025, if you have worked 40 quarters or 10 years, then you most likely qualify for a premium-free Part A, which means you don't have to pay for your Part A. If you pay into, FICA, Social Security, and Medicare on those taxes for all those years, that's what that money's going towards. It's going to pay for Part A. But let's say you didn't work a job that paid into Part A and you have to buy it. You can actually buy Part A. It's super expensive, but you can buy it. If you don't have even enough quarters to qualify for even a partial discount, if you got to pay for the whole thing, it's currently $518 a month for just Part A. And then if you just missed the quarter amount, so just under between 30 and 39 quarters, then you only pay $285 a month. Now, let's say you've never worked, but you're married and your spouse has worked all those years. You can get Part A coverage through their work history when you pick up your Medicare. So keep that in mind. If somebody's never worked, don't just instantly think that they got to pay for it. If they're married, if they have a spouse, they can generally qualify off of their married spouse. Now, we are going to do more on Social Security and those qualifications on another call, so we will dig into that more. But for the basics, if you've worked 40 quarters or your spouse has worked 40 quarters, then you have a $0 premium for Part A. And if you have no eligibility that way, you can buy it. Now, the deductible for Part A currently is $1,676. And if you notice there, it says per benefit period. That is a super important line item to make note of, because the Part A deductible is not a one and done deductible like traditional health insurance. When you think of a deductible, especially people coming off a group or AC or Obamacare, they're used to having one big deductible a year and then they met it and it's done, and then they'll have a max out of pocket. Well, the Part A deductible is not a one and done deductible. You can actually get hit with it multiple times a year. It depends on how you go in and out of the hospital. If you say you check in the hospital on January 1st for a heart attack, you're going to pay $1,676. And let's say within 60 days, you go back into the hospital for heart issues, chest pains again, they're not going to hit you with it again. But let's say if you go back into the hospital, 63 days later and you broke your foot, you're actually going to get hit with that deductible again. So in the first 60 days, it's a one and done deductible. From day 60 to 90, if it's for the same situation, then it's the same deductible. But if it's something different, then you're going to pay a new deductible. And then after day 90, everybody pays a new deductible. So it can get pretty confusing. I'm super accident prone. Tom, you're pretty accident prone. You might have done the math on this yourself. And generally, kind of rule of thumb, I think the most you can get hit with it in a given year, depending on, timing and everything, is about 5 times a year, which can really add up. So I don't ever want my clients to think that once they've met 1676, they're done, because they're not, because they can get hit with it again. Now, other things to know if you have an extended stay in the hospital. So my mom was once in the hospital for over 3 months. When you're in the hospital for an extended stay, you're going to get hit with the deductible. And then from days 1 through 60, your deductible applies. But then starting on day 61, you're going to start to incur a daily copay. So current year daily copay is $419 a day from day 61 to 90. And then if you're still in that hospital at day 91, you're going to pay $838 a day until you've maxed out your days. And at that point, if you're there past 150 days, you actually are absorbing all the costs. Now, if you're on a plan, it'll help offset those costs for you. They do have their limits as well, but there is a little more coverage there when you have like a plan to pair with it. But ultimately, Medicare says you get 150 lifetime reserve days. That's lifetime. That's not yearly. That's not every time you're in the hospital. That is lifetime. So once they're done, they're done. Skilled nursing facility. First and foremost, I want to explain what skilled nursing is. This is not long-term care. By any means, this is not long-term care. Skilled nursing, the idea of skilled nursing is you're going into a facility that they're going to do therapy on you to get you back on your feet to send you home. The whole goal of skilled nursing is to go home, not to stay. So if you're talking long-term care, that's a totally different product. That has nothing to do with Medicare. So skilled nursing, to get you home, days 1 through 20, skilled nursing is covered at a $0 copay per day. So your first 20 days of skilled nursing is covered under Medicare. From days 21 to 100, though, that skilled nursing jumps up to $209.50 per day. And then after days 101, if you're still there, you're absorbing all costs. Now, I don't know anybody that's been in skilled nursing personally over 100 days. Generally, my rule of thumb when I think of that is somebody's in that kind of care, one of two things needs to happen. They either A, need to go back to the hospital because obviously they can't figure out what's wrong with them and they need a new diagnosis, or two, they should be in long-term care because they just can't take care of themselves, and they will figure that out in skilled nursing. I've never seen anybody go over 100 days. If you have, please let me know or put in the chat, but I personally have not seen anybody go over 100 days in skilled nursing at any one given time. So when you think about Part A, it's inpatient hospital care. Generally, you have worked for it, so it doesn't cost you anything, but there is costs when you use it. Now, Part B is for kind of like everything else. It's for most of your outpatient stuff. So doctor visits, specialist visits, um, durable medical equipment and supplies, preventative services, cancer coverage. So like when you're getting chemotherapy and things like that, that's generally done as an outpatient setting. So that all goes under your Part B. Dialysis goes under Part B because it's generally done in an outpatient setting. So if you think of anything you go do, but you go home that same day, that's going to be an outpatient setting. And that's going to go under your Part B. Now, 2025 standard monthly premium of Part B is $185. Now, this is up about $10 from last year. Every year, again, just like Part A, all these go up. So Part B premium is going to go up every year. Now, with the Part B premium, everybody has to pay it. Unless you're by chance super low income and you can qualify for a level of Medicaid, then Medicaid will cover the Part B premium. But unless you qualify for Medicaid, everybody has to pay it. Now, some people that are higher income earners have to pay even more. And we call this IRMA. So depending on how much money you've made, depending on if you're single or married and how much money you've made, payment could range anywhere from like 185 all the way up to 628.90, depending on your income level. We will look at the income levels here in a minute. Also with Part B, you have an annual deductible of $257. This is $17 higher from last year. This goes up every year as well. Now, this is a one and done deductible. Unlike the Part A deductible where you can get hit with it multiple times a year, this is a one and done true annual deductible. But once you've hit it, you still have a co-insurance with Part B and it's 20%. Now it's 20% of Medicare approval, medically necessary, Medicare approved, but you'll pay 20%. And again, we're talking about doctor visits, outpatient therapy, durable medical equipment supplies, cancer treatments, things like that. But that 20% has no cap. So when you think about Part B, and I'm going through dialysis or cancer, and all I have is original Medicare, I have to pay the 20%, 20%, 20%, 20% every time I go, 20%, 20%. And even at the Medicare allowable rates, that starts to really add up. And if you're getting dialysis 3 times a week and you're doing it for the rest of your life, that could make you go broke. It could be very expensive. So to me, the fact that there's no cap on that 20% is kind of the scariest part about original Medicare because you have no safety net. You have no max out of pocket like you're used to on a traditional health insurance coverage. So there's no safety net. They just can keep billing and billing and billing. Now, something else to be aware of with Part B is you have to sign up timely. And if you don't sign up timely, then you can get hit with a penalty. The penalty is 10% for each year you didn't sign up. It's a full 12-month period. If you didn't have something like group health, coming off of credible coverage, generally like group health, things like that. VA benefits, for reference though, is not considered credible coverage for Part B. So if somebody is VA and they were late getting their Part B, they are actually going to get hit with a penalty. But a group health plan will waive the penalty because they had credible coverage for group health. Now, this is the current IRMA chart. Just for reference, you have single and married filing jointly and then married filing separately. You can get hit with IRMA on Part B and also Part D. I know we haven't talked about the drug plane yet, but it was on the side by side here. So you can get hit with that income adjusted amount for both Part B and Part D. So you'll pay more for both those parts of Medicare. And depending on where your income lies of how much you'll pay. And generally when I'm sitting with a client, I'll just ask them, I just kind of get real generic. I'm like, when we start talking about the premium, like, have you made more or less than $100,000? Like, I'm not even going to start talking about this unless they made over $100,000 because it's kind of a moot point. Now, it's a 2-year look back on IRMA. So let's say I currently am retiring 65 and have made a lot of money. I'm going to pay IRMA now, but in 2 years, Social Security will automatically look back. And if I'm just now living off my Social Security check for the last 2 years, they can adjust it back. Also, if you don't think it's right or you think you have a special circumstance, you can file an appeal with them to try to get the IRMA taken back where you don't have to pay it. I know a lot of people that really get hung up or mixed up on this when they sell a house in retirement and they have the capital gains portion, or they pull out of their 401k. That can really screw them up too. So those are ways that people can kind of screw themselves up without even realizing it. So now with this information, we go back to the Medicare card. And when I'm explaining to the client and we're looking at the card where you see this little arrow pointing to Part A, I put in on this top line, that's where I write the deductible. So I take that deductible as I'd explain what Part A is, and I'd write that deductible there as a visual. Then on the line underneath, I write the days 60 to 90 copay, and I write that amount there so they can visually see it as I'm explaining it to them. And then the third line here, I write the day 90 and above copay there. And then over on the Part B side, this arrow here, I write in what their premium, the standard premium should be. And then on this side, I talk about the first line is going to be the Part B deductible. The second line is going to be the Part B coinsurance. And the third line, I'm going to write in pretty aggressively, I'm going to write in no cap, and then explain that there's no max out of pocket, there's no cap, they can keep billing and billing and billing. And I use those line items, one, to slow the conversation down with the client, because as you become very versed at this, you can start going really, really fast, and it just goes whew, over the client's head. So sometimes we have to force ourselves to slow down because we know this and they don't. And the other way I also slow myself down with going this is my laminated card. I present it to them face up to where it's upside down to me. And I'm literally writing on those lines upside down. If you haven't seen me do it, I'm very proficient. I've gotten very proficient writing upside down. And fun fact, it kind of turns into a party trick for the client because about 3 lines in, they start to notice and they're like, oh my God, you're really good at that. And that also kind of helps break some ice. It's kind of just a fun fact. Now on these 2 lower line items, I'm very specific on what I write in here too. So I always put in these, I always put what Medicare does not cover. So, Medicare, just so you know, original Medicare Parts A and B does not cover prescription drug coverage. It does not cover your Part D, so it does not cover prescription drugs. It does not generally cover dental, vision, hearing. It does not cover long-term care. It does not cover your final expenses, life insurance, things like that. And I will write that stuff in down here. That way, when they look at this, they kind of have an overview, full visual of the expenses and what it does and does not cover, just kind of to start with. And I find that the clients they can follow that along pretty easily and they can keep up. And then, of course, as we go through it, they'll stop, they'll have questions, and then we can discuss it from there. Now, Part D, prescription drug medication. This is your Part D. there's been a lot of changes with Part D the last year. And if you're a new agent coming in now, Part D is actually way simpler for you to understand than it was for us when we had things called the donut hole that we had to explain. But one of the major changes for 2025 is the removal of the donut hole. So that's no longer a thing. Um, the 2025 cost monthly premium does vary by plan. I've seen it from $0 to over $100 depending on the plan. The national average currently is about $46.50. The deductibles, I've seen $0 deductibles all the way up to $590. $590 is the most a deductible can be in 2025, and that number does change every year as well. And of course, some plans don't have a deductible at all. So kind of think of the more expensive the plan, the smaller the deductible. They're basically just getting their money one way or the other with the client. So either they're going to pay it up in premium costs and they're going to get their money that way from the client, or they're going to front load the policy and get their money from the client in the deductible. But rest assured, Part D, they will get their money from the client. Out-of-pocket maximum for 2025, like I said, the donut hole has gone away. So there is a true out-of-pocket maximum now, which is $2,000. Now, the medication does have to be on formulary and it has to be, part of the plan for it to count. If you got a medication that's not on formulary, then that doesn't go towards your $2,000. Now, you could apply for an exception and get that through. And I've seen that go through many times with a carrier, depending on why. But they have to approve it. And generally on those exceptions, it's going to hit about a tier 5, which is still great because you're going to cap out at $2,000 now. So that's really good. And it is front loaded. I've noticed this year that it's really is front loaded. Most of that $2,000, if somebody's on high dollar medications, they're going to end up being mostly through it by the first quarter, if not the second quarter of the year. And then the rest of the year, they're not really going to pay anything for their medications. Something else to know that's different for 2025 that we have not seen before is there is a payment plan on Part D medications now. So you can set up a payment plan with the carrier and they're going to divide your medication cost by 12 if you set it in the beginning of the year, or 8 if you set it up, certain parts of the year. And they're going to divide out that money that you owe to the carrier as a payment plan. Fun fact, the client, if they abort on the payment plan, they still get their meds. They can't stop them from getting their meds, and they cannot report them to the credit bureaus. So forward facing here, a little more not basic Medicare, but I'm concerned about that as a whole because I see a lot of carriers going to eat the medication costs, and they're much smaller now than they were, and then they're going to eat them. So I'm predicting that we're going to see rate increases because they're going to have to cover those who aren't going to pay their theoretically their monthly payment with the carrier for their medications. Some other language you need to know: prior authorizations, which a doctor, the pharmacy could require a doctor approval from the plan or the drug plan before treatment. There's the process. The healthcare provider submits a request for prior authorizations to the insurance plan. The insurance plan reviews it, and then decision is either approved or denied. Step therapy. So in some situations, the carrier is going to request that they try a different medication. Usually it's less expensive before they'll approve this other medication if they've never been on it before, to see if that works first. And you can also get around that. Maybe you're allergic, or maybe you've had that medication, it doesn't work. So you just have to get the doctor involved to explain that to the carrier. Now, Part D also has a penalty. It is 1% of the national average for every month you went without coverage. And at day 63, you start to incur a penalty for Part D unless you have credible coverage somewhere else, like group health, or in this case, a VA. So where VA did not cover you for the penalty on Part B, VA coverage does cover you for the penalty on Part D, which I know can be very confusing, especially as a new agent. So if they're a veteran, their veteran drug benefits does count towards credible coverage on the drug portion of the plan, but not the medical B portion of the plan. And then, of course, group health covers, TRICARE, obviously, things like that have other credible coverage situations. Now, another fun fact to know, you have 63 days before the clicker starts counting. And remember how we said the part A and B effective dates could be the same or different? Well, when they're different, that's usually when a lot of people get into trouble with the Part D penalty, because they might have gotten Part A, let's say January, and for whatever reason, their Part B didn't get in effect till May, but they never picked up a drug plan or anything in between. Well, that 63 days clock started the minute they got their Part A or their Part B. It actually doesn't matter which one you get first. Whichever one goes into effect first, that 63-day timer starts. And if you don't have a Part D plan, even if you don't have the other half of Medicare, you're going to get hit with a penalty, because Part D, you only have to have either A or B, not both. You do not have to have both parts of Medicare to get a Part D plan, only A or B, where you'll learn in the future where with the other parts like Part C, Medicare Advantage Plan, or Medicare Supplement, you have to actually have both A and B to get that. And we'll talk about that later. But for Part D, you only have to have one or the other and not both. And the minute you have one, your timer starts unless you have credible coverage. Any questions on that? Christy, you've seen me do the upside down Medicare card.
Yes, I have.
I always think it's a fun party trick. The clients really like it. Um, if you guys are interested in getting a lemonade card, I use it for in-person appointments. I don't really use it for virtual, obviously, just do a picture like this, or I just talk over the phone. But if you're doing a lot of in-person appointments, especially as a newer agent, it's kind of a handy tool, because the way I have the line items on there, you're pretty much guaranteed not to forget to say something about the Medicare card, because if you do, you're going to have an empty line item, and that's going to trigger something in your brain like, what am I forgetting? What am I forgetting? What am I forgetting? So it's a nice little tool to use when you're initially just kind of learning Medicare and explaining parts A, parts B, and those kind of things. Now, there is a lot more on this Medicare train, but as new agents, I don't want to give you too much at once. So I'm not going to go any farther today, but I'm here for questions for anybody that has any questions about this.
The beautiful
So-
news is that WellCare has yet to bill me for any of my 15,000 and 19,000 medications so far I've taken.
Nice. Nice.
I'm still on the MSB and I maximized on my very first prescription, but they haven't billed me. Every time I get a WellCare letter come in, I think, okay, this is the bill. It says, we approved you for this medication. Great. So the key on the exceptions, on the exemptions, folks, is make sure you've got a very proactive doctor to get those exceptions. I've had a $9,000 medicine added to the formulary and a $19,000 per month medication added to the formulary, and this is on WellCare on the $0 plan. And let's say they've yet to bill me in 3 months. So I'm waiting. I know my $2,000 bill is coming, but it can happen. But it's doctor if your doctor's proactive, I'm building a case for the exception for the formulary. It can happen.
You're absolutely right. And customer service team has pushed a lot of these through. Shrew is always really great at doing it. Um, getting that exception, helping the client with the doctor and the carrier, getting them linked up to get the exception. They oftentimes will give the exception unless you're just asking for something that's just not medically necessary. Then you're going to have hard pressed getting that exception. But as long as it's medically necessary and the doctor has proof to why you need it or why you can't take this other medication, generally they will get it in there for you. All right, guys. Well, that's all I have for this. So I'm going to stop the recording